Welcome back to Navigating Cancer. I'm Dr. Joey Bennett along with Wendy Hall and our special guest tonight, Dr. Farhad Golkar, who is a surgeon at Inverness Surgical Associates, did a fellowship in hepatic and pancreobiliary surgery, which deals with tumors of the upper abdomen. A few weeks back, we had Dr. Carmaine talking about some tumors of the lower abdomen, and now we're moving up to the top. Just finished a very good segment on pancreatic cancer. And we want to spend this segment talking about the esophagus, and not just esophageal cancer, but what can lead to esophageal cancer and some of the things that you can do to help minimize the risk of having that esophageal cancer. So if we can go to the next slide, Bill. I mean, talk to us a little bit about the esophagus, because a lot of people have reflux.
Sure, right. As we all know, the esophagus is an organ that essentially takes food from your mouth to your stomach. And gastroesophageal reflux is a huge problem. I'm positive that everyone knows someone, if not themselves, who has acid reflux. And so with it being such a huge problem, and with a lot of people being on anti-acid medications, it becomes a huge financial concern. And essentially, you're stuck on these medications for life. And backing up to what Dr. Bennett said, gastroesophageal reflux can lead to esophageal cancer, which we'll look at in a second. It affects a lot of people, 20% of the population, and as I mentioned, $10 billion is spent on anti-acid medications. The next slide will show us what Barrett's esophagus is, which is an important thing. These are some symptoms that are pretty self-explanatory, but heartburn, pain, cough. Some of the symptoms are called extraesophageal symptoms, and those can include hoarseness, sinusitis, and pneumonias for people who don't have the typical symptoms.
Because I think a lot of people sometimes will come in with hoarseness and they attribute it to allergies or such, and you start questioning them and they'll tell you that, you know, I do have heartburn, and if you have the acid coming up through the esophagus and the trachea that goes to the lungs basically unite right at one area, and you can literally look in there and see where the acid is irritating the vocal cords.
That's exactly right.
So it means that any symptom that you've got, bring it to the attention of your primary care physician so that they can initiate further workup as they have it. But again, you know, heartburn is the most common thing that's associated with it.
Right.
Look at the next slide.
And so, briefly, when we're evaluating someone who has reflux, we do a variety of tests on them. One of them is an upper GI, which essentially tells me as the surgeon how well our esophagus works. The esophagus should essentially take a bolus of food, or basically something that you swallow, and propel it to the stomach with one peristaltic wave, or one contraction. Some people have abnormal esophageal motility, and those are people who I would need to know that have abnormal motility so that it would change the operation that I would do, and we'll talk about that on the next slide here. So first, before considering any operation, you should consider medical treatment. As I mentioned, those are anti-acid medicines, which we all have seen commercials for: Nexium, Prilosec, Zantac. And in addition, you should try other things like you see listed on the slide, such as weight loss, because that decreases the intra-abdominal pressure, stop smoking, avoid certain dietary substances such as chocolate, caffeine. And if we look at the slide here, you can see what I'm referring to. In the picture, you could see acid washing up into the bottom of the esophagus. You can see the gastroesophageal junction there, which is where the stomach and esophagus join. And that can cause burning and what's called Barrett's metaplasia. And that essentially is a situation where that's a precursor to cancer in the esophagus.
And I think if you pull out, Steve, and look at this, on the left-hand side of this picture, we'll go back to it in a second, that's the pinching of the GE junction that's supposed to stay closed, and on the right side, it's more open. You can go back to it now and see where the acid would reflux up. And Barrett's esophagus, you know, a Barrett's esophagus, or those changes, is not a good sign, because as you said, it can be a precursor to cancer. And I'm not sure right now we have really effective ways, if we find someone who has the Barrett's, the precursor to cancer, to be able to reverse those changes. And so we need to try to prevent them out front. And if we see them, you certainly have to try to prevent them from becoming worse, right?
Right, that's exactly right. So what you want to do is prevent progression of Barrett's, because that'll become cancer. There are some modalities endoscopically that GI doctors can do to try to treat Barrett's. None of them have been really that effective. And I want to comment on something Dr. Bennett said. On the picture, you saw the gastroesophageal junction on the left side is pinched. That's normal, because that should be how acid is blocked from entering the esophagus. But in people who have an abnormal gastroesophageal function, it's wide open and lets the acid wash up, which is a good segue into the operation, which is on the next slide.
So there is a way to surgically stop this from happening in people who don't respond to the other techniques that you talked about.
Exactly. Once medical therapy has been tried, like we saw on the other slide, antacid medications, dietary changes, and weight loss, then surgery would become an option. And the surgery is depicted on this slide here. Essentially, I'm recreating that gastroesophageal valve, or that tight area that you saw in the picture before, by taking the top of the stomach, which is very floppy, and wrapping it around the esophagus, as you see depicted in the picture. And this has been shown time and time again to halt the progression of Barrett's and even regress it somewhat.
Now, how do you know how tight to make that? I mean, experience?
No, at the time of the operation, we put a dilator in the mouth called a bougie dilator, and essentially we sew it around the bougie, so you don't make it too tight and you don't make it too loose.
Perfect. So, now, if in people who don't have this and who have Barrett's esophagus, a lot of them will go ahead and progress to esophageal cancer. And I think we look at the next slide. Esophageal cancer, much like pancreatic cancer that we talked about in the last segment, these tend to be very bad cancers. And talk about those a little bit.
Exactly. So the symptoms of them are, as you see listed here, weight loss, difficulty swallowing food, food sticking, regurgitating of food, and then sometimes bleeding, either throwing up blood or blood coming out the other end. And so typically these are diagnosed by someone having those symptoms and a gastroenterologist performing an upper endoscopy, where they put a camera down the mouth and they go to look at the esophagus and they see a cancer there, and they're able to biopsy it, and then we have a confirmation of the diagnosis. Then typically patients need to be staged, meaning I need to know how aggressive the cancer is, and that's done with a variety of tests such as a CT scan, a PET scan, and esophageal ultrasound. And then once they're staged, if they have more advanced disease, they need to see a radiation oncologist like Dr. Bennett and a medical oncologist to get started on chemotherapy. And then after they finish a course of chemotherapy, then they would have surgery. And those people who have early stage tumors can go directly to surgery, which is the next slide here. And this is the operation, and I've summarized what I just said above about stage 1 and 2 versus stage 3 and 4 disease. There's two ways to remove the esophagus. One of them is called a transhiatal esophagogastrectomy, and the other one's called an Ivor-Lewis esophagogastrectomy. And essentially, they have the same outcomes, but ultimately what we do is we remove the esophagus either through an incision in the abdomen and in the neck, or an incision in the abdomen and in the chest. And we have to reconstruct the esophagus by turning the stomach into a tube and pulling it back up and connecting it to the upper end of the esophagus. It sounds quite dramatic, but ultimately patients do very well.
I mean, he makes it sound so simple, and again, this is a very difficult procedure. We'll talk a little bit more about this when we come back to the next segment about radiation, chemotherapy, and surgery together for esophageal.